All right. iPhone says 12:33. Good. All right. Welcome to the South Texas Regional Family Medicine Grand Rounds. Our educational partner today is the South Central Area Health Education Center. Our department's mission statement is inventing a healthier future for families and communities in San Antonio, South Texas, and beyond through excellence in patient-centered care, research, and education. Thank you in advance today for our virtual guests muting your microphone once the presentation begins and being attentive to the presenters and engaged in the session, keeping your cameras on when appropriate. Also, thank you in advance for registering for CME credit for each session and for completing and submitting a session evaluation form at the end of the session. Today is October 11th, 2023. The activity code for today is 10093218. You can claim this credit using the CME credit via text system. If you have not registered yet, please text your email address to the toll-free number on the screen, 844-502-1338, and then text attend 10093218. You must register for each session by midnight in order to receive CME credit. I'll leave that on the screen for a minute. All right, so it's just a brief overview of the new CME system, CME credit via text. Again, the activity code for today, October 11th, 2023, is 10093218. All right, and here are some instructions on how to access your CME transcripts, should you ever need them, from UT's CME office. For our American Academy of Family Physician members, you can use your AAFP login and claim credit for this activity at the link on the screen. This activity, the South Texas Regional Family Medicine Grand Rounds, has been reviewed and is acceptable for up to 1.0 prescribed credits by the AAFP. Physicians should claim only the credit commensurate with the extent of their participation in the activity. The Family and Community Medicine Grand Rounds address nationally established physician core competence, the following nationally established physician core competencies: the Institute of Medicine core competencies, the ABMS, ACGME competencies, and the AAMC competencies. Our presenter today, Christopher Alcorta, MD, has no financial relationships with ineligible companies to disclose. And Dr. Nader will now introduce our presenter.
Okay. So on behalf of our chairman, Dr. Hyan, and the faculty, I'd like to welcome you to this version of Family Medicine Grand Rounds. Our presenter today is one of our senior residents, Dr. Christopher Alcorta. This is part of our poem series, Problem-Oriented Evidence That Matters. His presentation is going to be about hypnotic agents are effective for insomnia, but at the expense of adverse events. I'll turn that over to you.
Let's see here. Is there any way I can have the laptop like?
This is very long. It's long enough. It's just a thick.
There you go.
All righty, there we go. So like you said, Dr. Alcorta, PGY3 family medicine resident. So today we're going to be talking about insomnia, more specifically, the pharmacologic management of insomnia. So first, we're going to define insomnia disorder. Then we're going to summarize our current guidelines for management. And then we're going to analyze a recent meta-analysis study regarding the efficacy, acceptability, tolerability, and safety of several hypnotic agents. And then we're going to apply this data to our clinical practice in selecting appropriate pharmacologic treatment for insomnia in adults. So for some background here, so insomnia is a common outpatient complaint. There is an estimated prevalence of 12% to 20% in the general population. So insomnia is a chronic course with symptoms that persist in individuals for 86% after 1 year, and then even 59% after 5 years of having a formal diagnosis. And then insomnia is associated with reduced productivity, increased absenteeism from work, increased accident risk, and it's estimated that insomnia costs over $100 billion per year. And as we all know, insomnia is a risk factor for worsening mental health conditions such as depression or anxiety and substance abuse. worsening medical conditions such as diabetes, high blood pressure, CAD, and then worsening quality of life and mortality. So we're going to first start by defining our insomnia disorder. So we're going to use our tried and true DSM-5. So note in the past with the DSM-4, this used to be called primary insomnia. Now it's called insomnia disorder. So insomnia disorder is the predominant complaint of dissatisfaction with sleep quantity or quality associated with one or more of the following symptoms, either difficulty falling asleep, difficulty staying asleep, or having early morning wakings with the inability to fall back to sleep. And this sleep difficulty has to be present for at least 3 months. And because insomnia disorder is a disorder, this sleep disturbance must cause clinically significant distress, has to occur at least 3 nights per week, has to occur despite adequate opportunity for sleep. And then you also have to rule out other sleep-wake disorders such as sleep apnea, narcolepsy, or circadian rhythm disorder. Another important thing is that psychiatric conditions and other medical conditions have to not explain the predominant complaint of the insomnia. And another important thing is to rule out medication side effect or a drug that a patient may be abusing. So there's a lot of conditions that are associated with insomnia. So for medical conditions, hyperthyroidism can cause insomnia. CHF or COPD is a patient not able to breathe well while they're sleeping. Dementias or so much neurocognitive dysfunction that their circadian rhythms are thrown off. Chronic pain, or they're in so much pain they're not able to fall asleep. BPH or incontinence, are they going up to the bathroom every 30 minutes to sleep? And most important, medication effect or substance use. Also for a big challenge for us physicians with psychiatric conditions. So psychiatric conditions and insomnia are a two-way street, and sometimes it can be difficult to see, is the worsening insomnia causing worsening psychiatric conditions, or is the worst psychiatric conditions causing the worsen insomnia? So we see that insomnia is present in depression, anxiety, PTSD, bipolar disorder, and psychotic disorders. And then insomnia can also be seen in our sleep-wake disorders, such as narcolepsy, OSA, circadian rhythm disorders, and also restless leg syndrome. So now I'm going to go over our current guidelines for management for insomnia. So this is based off the American Academy of Sleep Medicine. So our first initial step for treatment are non-pharmacologic methods. So that's going to be treating those comorbid medical and psychiatric conditions. That's going to be modifying these medications that they're using or substance use. It's going to be optimizing the sleep environment or recommending sleep hygiene practices. And the most important one are psychologic interventions, so cognitive behavioral interventions. There's sleep restriction therapy, stimulus control therapy, and relaxation training. And we do have meta-analysis data that suggests these psychologic interventions produce clinically significant results that can last even a year after therapy. And then here comes a more important challenge here is when to initiate pharmacotherapy. So there's not a lot of clear guidelines on when to establish, when to initiate medications. So this is all on an individualized basis. So if a patient didn't have a good response to CBT or other conservative measures, or they're having sequela of untreated insomnia, are they falling more? Are they more cognitively impaired? Are they having worsening daytime sleepiness? Or is the insomnia getting in the way of treating their psychiatric or medical disorders? And then that would be when to open up the discussion of starting medication management for the insomnia. And there's other factors too that go along with this, such as age, medication adherence, and history of substance abuse. So second-line therapy would be to initiate short-term hypnotic medications. So here are some medications here. So we're going to go over all the medications used in this upcoming study here. So they're recommended for first-line agents, if we do decide on the medical route, is suvorexant, azopiclone, zolpidem, triazolam, temazepam, ramelteon, and we'll go over these medications later. They also don't recommend starting trazodone or diphenhydramine or melatonin for the treatment of insomnia. And they also go on to note that there's sparse long-term data for these medications. Here's an image from that meta-analysis I pulled. So as mentioned in the previous slide, there is a weak strength of recommendation. So I don't know if you can see that there. It may be so small from far away, but there's suvorexant. We have our Z drugs here, some benzos. They don't recommend ramelteon, trazodone, diphenhydramine, or melatonin, but we'll go through more into that in detail later. So for more background here, the FDA has approved these medications for treatment of insomnia disorder based on evidence from only short-term and placebo-controlled trials. And because the evidence is only from short-term trials, pharmacologic treatment is recommended only for the acute management of insomnia disorder. And these treatments have mostly been investigated in placebo-controlled trials, meaning comparing one medication against placebo. So little information is available on comparative effectiveness between medications, such as one medication versus another. And then the authors go on to cite that lack of training with cognitive behavioral interventions and availability of behavioral health staff limit the use of non-pharmacologic strategies. And they also go on to say that medications are often easily prescribed due to accessibility, despite being associated with adverse events. So other studies that have been done prior to this study were meta-analysis. However, they noted that these populations with the studies only focused on older adults greater than 60 or adults who are diagnosed with autoimmune diseases. So I found another meta-analysis here, quote, cited there at the bottom, published in Sleep Journal in 2021. That study only focused on adults greater than 60 years old. And they found that for starting medication management, they recommended azopiclone and low-dose doxepin. However, these authors went to branch out into adults 18 with no age limit for pharmacologic treatment for acute and long-term management. So we're going to be going over this meta-analysis that was published in Lancet Journal last year in 2022. And the clinical question here is, are hypnotic agents safe and effective in managing insomnia in adults? So this study design was a systematic review and a meta-analysis of randomized controlled trials with a goal of estimating the comparative effectiveness of licensed and non-licensed pharmacological treatments for acute and long-term treatment of adults 18 and older with insomnia disorder. And with this study, so 36 licensed and non-licensed medications were involved with this study. So for the systematic review, they did a review of randomized controlled trials comparing pharmacologic treatment for insomnia against placebo, with monotherapy as a major thing for adults with insomnia disorder that's according to diagnostic criteria, such as the ICD-10 or DSM or other international criteria. And from that systematic review, they pulled out 170 randomized controlled trials. Then for the meta-analysis, they only included double-blind randomized controlled trials involving medications indicated for insomnia by the FDA and other international regulatory agencies. And from that, they pulled 154 double-blind RCTs that were eligible. So exclusion criteria for this study were studies involving barbiturates. So there are some barbiturates that are FDA approved for the treatment of insomnia. However, they're left out of the studies due to their adverse events. Studies that had unapproved, unavailable, or discontinued drugs, such as chloral, ethchlorovinyl, and triclopos. I actually looked these up. So these were used in the 1950s for insomnia and later got phased out when barbiturates and benzos became more prevalent. They also threw out studies with medication dosages that were not in the therapeutic range, studies that had cluster randomization or crossover trials, or studies that involved patients with secondary causes of insomnia. So there are 4 primary outcomes that the researchers were looking for. So the first one was efficacy. Efficacy was defined as the patient-rated quality of sleep or satisfaction measured by sleep index. Acceptability, which is the proportion of patients who stopped the treatment for all causes. Tolerability, which was the proportion of patients who withdrew from treatment due to any adverse event. And safety, number of patients with more than one adverse event. They also had secondary outcomes here. So they had measures of sleep onset latency, wake time after sleep onset, total sleep time, number of wakings. And they did this objectively based on polysomnography results, or subjective, which were patient reported. They also had hangover, which they defined as sedation and reduced alertness during the day, rebound or withdrawal phenomena from these medications, or patients with serious adverse events. And then we go on to define what an adverse event versus a serious adverse event is. So with a common adverse event, so the authors of the paper used MedDRA, which is an adverse event classification dictionary that pulls adverse events from these journals and lists them. However, looking through the article and then looking through the 300-page supplemental document, they didn't really stratify these adverse events. They kind of lumped them up under one umbrella. So we're not sure if this is either causing nausea, falls, broken bones, headaches. They're all lumped under the same category of adverse event. Another thing is a serious adverse event, which is defined by the FDA, which is an adverse event that results in death, life-threatening, causes hospitalization, disability, etc. So study selection process, I'm not going to go through this whole image here, but out of the whole literature review, they pulled out 154 double-blind RCTs that were eligible for their network meta-analysis. So now we're going to go over the test drugs that they use for this study. So the first class of medications were the benzodiazepines or the benzodiazepine receptor agonists. So all these have the effect of enhancing the action of GABA at the GABA A receptor. And as we all know, these are controlled Schedule 4 drugs. They stratified the benzos in 3 categories: short acting, intermediate, and long acting. So for short acting, they have alprazolam and midazolam. And then these two I'm not too familiar with, brodiazolam and triazolam. Intermediate acting, the ones with a half-life of 6 to 24 hours. They used lorazepam, or as we know, Ativan. They also have temazepam, loprazolam, and estazolam. And then they also had long-acting benzos there: flurazepam, nitrazepam, and quazepam, which I'm not familiar with at all. But anyways, so longer-acting benzos that are maybe more familiar with, such as diazepam, clonazepam, they're not FDA approved for the treatment of insomnia based on their half-life. But all these medications that are listed here on this slide are also all FDA approved. Our next class of drugs are our non-benzodiazepine receptor agonists, or more easily known as Z drugs. So these have the same mechanism of action as our benzos. So these also enhance the action of GABA at the GABA A receptor. And these are also all Schedule 4 drugs. So our first one here is zolpidem, as we're more familiar with Ambien. This one has a half-life of 2 to 3 hours. And then as you can see here, these have shorter half-lives than most of the benzos there. These are very quick acting, quick process drugs. So zolpidem has a half-life 2 to 3 hours. It shows its onset within 30 minutes and has a peak effect within 1 hour. There's also zopiclone, which the brand name is Zimovane. This one's not available in the USA. It has a half-life of 5 hours, peak effect in 2 hours. Next one is ezopiclone, or Lunesta. You may see in the commercials on TV at some point. Has a half-life of 6 hours and shows its peak effect in 1 hour. Next one is Zaloplan, which is the most fast-acting one on this list, otherwise known as Sonata. It has a half-life of 1 hour, has a peak effect in 1 hour. Then our next class of drugs are the dual orexin receptor antagonist, or DORAs. So these inhibit the effect of orexin by acting as antagonists to the orexin receptors OX1 and OX2. So these help regulate neurotransmitters associated with wakefulness, such as histamine, acetylcholine, dopamine, serotonin, and norepinephrine. And like our first 2 classes of drugs, these are also all Schedule 4. So our first one is limborexant, or Dayvigo. They're pictured on the right. These have longer half-lives compared to our Z drugs. This one has a half-life of 17 to 19 hours, but these also have a very quick peak effect and onset time. Onset time of 15-20 minutes and a peak effect of 1 to 3 hours. Other medications here are suvorexant or Belsomra, about the same, has a half-life of 12 hours. And then there's daridorexant, Quviviq, has a half-life of 8 hours, very fast onset time, very fast peak effect time. And then our last one in this category is seltorexant. This one's not currently available. It's currently only in phase 3 trials. And what's unique about this one is that this one specifically works on the OX2 receptors. Then we have our melatonin and melatonin agonists, or agonists singular. So there's melatonin, and we know it's secreted by the pineal gland. It helps regulate our circadian rhythms. And then there's Ramelteon, which also works on these melatonin receptors in our body. And then we have over-the-counter antihistamine. So these are also approved by the FDA for treatment of insomnia. There's diphenhydramine, Benadryl, and doxylamine, Unisom. And then next are antidepressants with antihistamine effects. So we have our TCAs, doxepin and trimipramine. These are also FDA approved, but other medications such as mirtazapine, quetiapine, or Seroquel, those are not FDA approved for treatment of insomnia. And same can be said for trazodone, which has a combination antihistamine and alpha receptor blockage. So now we'll go through the results of this study. So as I said before, there was 154 trials that were selected for this meta-analysis. 13,000 participants were assigned to placebo. About 35,000 were assigned to the medication. The mean study sample size was about 265, mean age of about 51.7. 53% of these studies included adults between age 18 to 65. 9% of the studies included adults greater than 65. 39% of the studies had no age limit, meaning 18 with no cap to the age of the study. And then most participants, 63% were female. 89% of the patients were recruited outpatient. 42% of them were North American patients. 81% used the DSM, depending on what time the study was done, as their standard criteria for insomnia diagnosis. And then 52% of these studies they found were funded by pharmaceutical companies. And then with the analysis of bias, 48% of these studies were considered low risk. And of the ones funded by the pharmaceutical companies, 20% had unclear risk, 32% had high risk. And then for treatment duration, for the acute treatment, they found a median of about 2 weeks. Most studies use between 2 and 4 weeks of studies, 2 or 4 weeks of treatment duration. And for long-term treatment, they had a median duration of about 25 weeks, between 19 and 26 weeks. So now we're going to go over our data here. So these are, let's see. So these are, don't have my notes here. So these are so plots for the medication there. So just going around, each of those are the test medications, and each 4 of those represent our 4 primary endpoints. The top left, quality of sleep. B, all-cause dropouts. C, dropouts due to adverse events. D, with patients who had any adverse event. So the size of the nodule represent the number of patients who were assigned to that group. And the thickness of the line represents the randomized controlled trials that were the amount of randomized controlled trials between the 2 medications. So as you can see, for all 4 of the primary endpoints, there were a lot of comparisons between zolpidem and placebo. A lot of them had comparisons against placebo, but not a lot of them had comparisons against each other. So now we proceed to our next image here. So this one's the result of the meta-analysis here. So this is a busy image. So let's break this down. So the dark blue boxes there are all the treatments. I don't know if you could read it there, but the top 3 blue boxes are the benzos, short, intermediate, long durations, and each one of them are different medications there. The red box in the middle is placebo. And if you go down the column and go down the row, that's the data of comparison for the primary endpoint. So the blue section here is the efficacy, and that was reported as standard mean difference. So each one of these is comparison for the standard mean difference of sleep index. So the light blue boxes there are the short-term duration. The dark blue boxes there are long-term duration. The side with the red, that was acceptability, which was dropouts due to all causes there. Light red is acute. Dark red boxes are long-term. And then there's going to be better visual representation of this data later in the presentation. So don't worry, this is a lot of information here. So this is also for the other 2 endpoints here. To the left is tolerability, and to the right is safety. So here's where the results of the study. So I'm going to be throwing out a lot of comparisons here, but there's going to be a visual representation of this data later. So for efficacy, that was their first primary endpoint. That was the patient-rated quality of sleep or satisfaction that was measured by the sleep index. They saw in the short term that all benzos, doxylamine, most of the Z drugs, zopiclone, zolpidem, zopiclone, and limborexant, one of the orexin antagonists, were more efficacious than placebo in the acute treatment. And then certain comparisons they chose to highlight were zolpidem and azopiclone were more effective than Zaloplan. And if you remember, Zaloplan was the more faster acting Z drug. The short acting benzos were more effective than all of the orexin antagonists, Zaloplan and zopiclone. And for long-term treatment, they saw that azopiclone and limborexant were more efficacious than placebo. They saw that azopiclone was more effective than Ramelteon and zolpidem. However, they go on to note that there wasn't a lot of good long-term data for with benzos and most other medications here. And as you can see in these boxes here, the dark blue boxes, dark red boxes with the dash there, that means there's no long-term data for that comparison. For acceptability, that was our other endpoint here. So that was the proportion of patients who stopped treatment for all causes. In the short term, they saw that intermediate and long-acting benzos and ezopiclone had fewer discontinuations due to any cause compared to Ramelteon. And for long term, they saw that ezopiclone and zolpidem caused fewer discontinuations than Ramelteon. For tolerability, they saw that, which was the proportion of patients who withdrew from treatment due to any adverse event. They saw that zopiclone used in the acute phase and zolpidem in the long-term phase caused more dropouts due to adverse events compared to placebo. Zopiclone caused more dropouts due to adverse events than ezopiclone, daridorexant, and suvorexant. And they saw that doxepin, seltorexant, and zalopon were well tolerated in their comparisons. And then lastly is safety. So that was a number of patients with greater than one adverse event. So benzos, most of the Z drugs, ezopiclone, zolpidem, zopiclone, had more adverse events compared to placebo. Doxepin, seltorexant, and zalopon, which they said were well tolerated. So here's some visual representation of the data. So these are Vitruvian plots there of all these other test medications. So the ones I chose to include on this slide are the benzodiazepines on the top, and then the bottom two, which are ezopiclone and limborexin, which the authors chose to highlight. So we see with our plots here, so to the left is acute treatment and to the right is long-term treatment. And then at the bottom are the adverse events. So we see with the short-acting benzos, also with the blue circles there are rates on the placebo. And then the gray boxes there are rates with the test drug there. So with the short-acting benzos, 16% assigned to placebo had improvement, but compared to short-acting benzos, 30% of the patients had improvement there. It has so the way they do statistical significance here is rated by the color there. The more intense the color, it's associated with more statistical significance. More green equals favoring more of the test drug. Red means not favoring the test drug there. So we're seeing with all the benzos, like I mentioned before, that they're having efficacy, that patients are reporting improvement on these medications in the short term. And that's on the top right, and that's on the top left there. On the top right, which is long-term, there's no data there for the long-term management with these drugs. So there was no numbers there reported. And also, as we can see here, the adverse events, we see they're big, red, and glowing there. So 42% of patients assigned to placebo had adverse events compared to 54% assigned to the short-acting benzos, intermediate 50%, long-acting 58%. So we're seeing with these drugs that they do have some efficacy there, but they're also having some statistically significant association with adverse events. Then at the bottom two, ezopiclone and limborexant. So we see for the short term and the long term, there's statistically significant improvement in sleep efficacy there. Also with limborexant. Also, we can see with ezopiclone that it's having more patients with adverse event on this medication. However, with limborexant, we can see that there's not a lot of statistical significance or not a significant association with adverse event on that medication. So they called it inconclusive. So I go on to list out these other medications here. So ezopiclone on the top left, I'm comparing it to all the other Z drugs there. So zolpidem in the acute phase, also showing some efficacy, also showing some significant association with adverse events. Same thing with zolpiclone on the bottom right. And then zalopon has a lot of inconclusive data across the board there. And then here's our DORAs, or orexin antagonists. So as we can see here, limborexin, good for acute and long-term. Seltorexin actually had a favorable adverse effect profile there with noted less patients reporting adverse events on that medication. Daridorexant and suvorexant also kind of showing some middling, maybe some improvement, maybe not. And then other medications on here, Ramelteon, melatonin, not really showing significant data either way. Doxepin having some, maybe not improvement. doxylamine having some statistically significant improvement, but not a lot of data on this one regarding long-term management or adverse events. So limitations of the study. So the limitations the authors go on to quote is that they say there's very few studies that evaluated the long-term treatment of insomnia. And we can kind of see that with very little few data that we had on long-term comparisons. They had many low or very low quality comparisons, especially for these long-term time points that they did have. Many trials did not report adequate information about their randomization. Some of these trials also included sleep hygiene practices with the pharmacologic treatments, which could add confounding to the results. Going to say the cost-effective analysis was not performed. And then data about specific adverse events were reported inconsistently. And that kind of goes back to where I said with the adverse events, whether there are falls, nausea, broken bones, heart attack, we don't know. They're all lumped up in the category of adverse events. So how does this apply to our clinical practice? So for our first line management of insomnia, so would recommend no changes there. We would first start out with our non-pharmacologic treatment strategies, CBT, sleep hygiene practices. We do have good meta-analysis data that shows that this works pretty well. The biggest change to our clinical practice would be where we go with our second line management. So going to say that the azopiclone and the limberexin had a favorable profile for both the acute and the long-term treatment. However, the azopiclone had pretty substantial adverse effects rates, and the limberexin safety data was also non-conclusive. They also go on to say that all the benzos, short, intermediate, and long-acting, were also effective for short-term management. But as we can see, most of these medications had a lot of adverse effects associated with them. So these medications come with safety risk involved. So that shows the double-edged swords of hypnotic medications. They work, but they also come with safety risk. So there's a lot of individualized shared decision-making and then discussion of risk and benefits that may be discussed with the patient prior to starting these medications. Other things to consider too, that these benzos and Z drugs, they also work on the GABA receptor. So also like benzos, the Z drugs also require tapering for discontinuing. And then finally is the cost. So a lot of these medications are not off patent. They're very expensive. And then we got to keep that into consideration, especially with our patient population that we have here as well. So otherwise, that's the presentation. I'll be taking questions at this point. I'm sorry you sound like Donald Duck right now. You're or like Donald Duck underwater.
How about, is this better?
There we go.
All right. So 3 questions I have for you. First question, you may have said this, but I may have missed it. Did they try to find unpublished studies? Because meta-analyses really are supposed to be trying to get a complete look at the literature, whether published or unpublished.
They did, yes.
Second question is, did they assess the studies for heterogeneity? In other words, are all the studies finding similar results? Are they in agreement, or do we have different populations of study? And the third one, because you said that there was a real range in the quality of the RCTs, did they look at whether the results of the study correlated with the quality of the study?
So for the first one, I know for a fact they used unpublished studies. I don't know the second one, the assessment of heterogeneity off the top of my head. And then what was the third question again?
Third one is, because there was a range in quality on the RCTs, did they look at whether the quality of the study correlated with its findings?
So there was a range in the quality of evidence, or a lot of low quality comparisons is what they noted. Yeah, I'm not sure I can answer that one.
So I know you said like don't do Krasnow. Like, is that what this paper said, or is that like a new thing we're not supposed to do Krasnow anymore?
So they didn't make any recommendations on trazodone. With these plots here, they kind of excluded trazodone for this one.
You just said it wasn't FDA approved, that is.
Mm.
Helps with depression because sleep is but it was pure insomnia.
All right. Are there no more questions?
Hey, Dr. Alcorta, Byron Hepburn here. Can you hear me okay?
Yes.
I may have dropped off there for a second, but could you comment again on the efficacy or non-efficacy of the melatonin? I know you mentioned it earlier on that, not being effective, but could you just elaborate a little bit, please?
Yeah, so I can go on this slide here. So this is the data that they pulled from melatonin. So they didn't find any significant improvement on the melatonin there. As you can see, placebo rate 16 and then treatment rate 18. They said it was not very efficacious there in their study.
Yeah, for the residents, I mean, you're going to see a lot of your patients are de facto using that. So just to be able to speak to that science would be very helpful. Thank you.
Great.
The first line of the questions, which one of the second line?
So you can always, like, if one option doesn't work, you can try different dosages as well, or you can consider switching agents. So if they've been on like one medication for a long time, you would have to taper to discontinue, especially if they've been on like a benzo or Z drug for a long time and you want to try like something different. I know there's like different taper guidelines out there, like switching guidelines, but I don't really cover that in this presentation. All right, there's no more questions. Thank you, everyone. I hope you have a good afternoon.
Thank you.